Okay. Hello. Am I audible?
Yes, sir.
Okay. So should we start? Okay. Okay. Today we will be talking about epilepsy surgeries. So my aim is to give you a brief introduction of epilepsy surgeries and how they are conducted. So many of you must have read the definition of epilepsy. It's hypersynchronous discharges, excessive discharges, neuronal discharges, abnormality, and provoked, unprovoked. These are the words in a technical definition of epilepsy. And my aim is not to give you a technical definition of epilepsy. I will tell you what the real definition of epilepsy or the real epilepsy looks like. Let me know if you can see the video. Can you see the video?
Yes, sir. I can see that.
That is epilepsy. Look at this. This is epilepsy. This is called as reflex epilepsy. Whenever somebody hits you from the back, every time this patient will go into seizure. This is epilepsy. Look at this carefully. This kid used to fall like this. The mother is trying to put a slap on his cheek so that to deliver the. So that is epilepsy. This is a young football player. He used to have like
Young football player.
seizures like this every week or maybe every alternate week. Epilepsies. To understand properly, one should understand what exactly it looks like. So, not going into a technical jargon of epilepsy, I normally define, or it is of course a definition. So, epilepsies are basically of two types. One is idiopathic, where we don't know the cause. And the other is symptomatic, meaning there is some structural malformation is in the brain. And third one is cryptogenic, meaning we have a very strong feeling that it's a symptomatic, meaning that there is some structural malformation is present in the brain. But with the present investigation, we are not able to find it out. So ideally, there are two: idiopathic and symptomatic. Now, there are classically there are hints to diagnose idiopathic epilepsy. So idiopathic epilepsies are generally benign epilepsies, meaning they will have one or their frequency, seizure frequency is very low, once in a year. Generally, they respond to one drug, and they are easy to treat. But symptomatic epilepsies means there is a structural malformation or there is some structural cause to the epilepsy. Those epilepsies are generally drug resistant, meaning they will keep coming again and again. Their frequency is very high and they generally do not respond to drugs. So that's how we identify it. No, I don't know. Most of the people are practicing here and would be knowing what exactly, what do you do once the generalized epilepsy or epilepsy is diagnosed, epilepsies are mostly self-limiting. Generalized epilepsies are mostly self-limiting. They will start here, where you will add one drug here, anti-epileptic drug. Normally, the natural history of the disease is they will have a onset of epilepsy here. They will reach at a plateau, and then they will come back again, and they will disappear here. So ideally, what we do not want this kind of seizures in this period of 3 to 5 years. So we put one anti-epileptic drugs here, and the patient does not get seizure for these 4 5 years, and then we stop the medicine. That's how most of the epilepsies are, as we know, and that's why the notion is there that whenever the epilepsy is there, most of the doctors or even patient relatives are aware. अच्छा 3 4 साल दवाई लेना पड़ेगा, फिर उसके बाद ठीक हो जाना है, फिर बंद कर देंगे. असं आपण नॉर्मली काउन्सिल करतो पेशंट्सला. So that is the reason why, because most of them are epilepsy, generalized epilepsies or benign epilepsies or self-limiting epilepsies, and anti-epileptic drug is just to control the seizure. It doesn't control any root cause why the seizures are happening. So it is in my analogy, anti-epileptic drugs are just like a paracetamol given for fever. So we do not, we understand as a doctor that most of the fever are viral fever, and they are anyway going to settle in another 3 4 days. So whenever patient comes to us with a fever, we generally prescribe paracetamol. Similarly, here whenever patient comes to us with the epilepsy, we believe that it's probably a generalized epilepsy or self-limiting epilepsy or benign epilepsy, and we prescribe one anti-epileptic drug, and it will vanish over a period of 4 to 5 years, and we will stop the drug. But when the fever recurs after 4th day, or doesn't go or doesn't settle after 4th day, then most of us will try to reevaluate, get a culture, get a hemogram or a TLC or whatever, so as to find out the cause. So same thing happens with the epilepsies also. When you put an anti-epileptic drug, all the benign epilepsies should respond, and their frequency should be once a year, but that doesn't happen. And even after starting an anti-epileptic drug, patient come patient comes again and again with the seizures, and not responding to the drug. Then we should think about some structural cause, and that's the whole process. So what is the standard of care currently? We start them on appropriate drug. The drug should be appropriate. You cannot start Eptoin for this JME and all, because it will worsen the frequency. And at the same time, you cannot start carbamazepine. Basically, so you should start an appropriate drug. Then dose should be appropriate. Most of the doses are generally low, so they should be started in an appropriate dose. Patient should eat all the anti-epileptic, because many patient may not be. आपल्याकडे तर असं आहे की पैसे नाही मिळाले तर बरेच वेळा लोक महिना महिना औषधच घेत नाहीत. So good compliance should be there, and adequate time should be there. So what is the present treatment? What we do? Drugs, more drugs, few more drugs. So ideally what should happen is, once the patient fails on 2 drugs, ideally the situation here is, if you have a epilepsy, newly diagnosed epilepsy, there is a good chance that your first drug would control the epilepsy in 50% of the cases, meaning they are self-limiting benign epilepsies. You don't have to worry about them. But if continues to have seizure, then we would add another drug, appropriate drug. The another drug controlling the seizure is just 15%. So with these 2 drugs controlling the seizure is 65%. Now, henceforth, if patient fails 2 drugs, then whatever treatment you give, whichever drug you add, it's not, the chances of that drug controlling the seizure is less than 1 to 2%, meaning very low. So ideally, when 2 drugs fail, we call them drug-resistant epilepsy. And when we call them drug-resistant epilepsy, we should have a very clear-cut idea that we are looking for a structural cause, and we are looking at a symptomatic epilepsy. And as we already discussed, it is anti-epileptic drugs are just a paracetamol to the fever. So these anti-epileptic drugs are not supposed to take care of the structural cause. So ideally, we need to do some surgical stuff for that structural cause, and then only patient will be cured. So this is more or less a standard protocol. So you have to establish the drug resistance. Whenever patient do not respond to 2 appropriately administered drug in appropriate doses with good compliance, patient is labeled as a drug resistant case. And all the drug resistant cases should be evaluated for finding out the structural cause. We are not saying surgery, but we are saying for structural cause. So what do we do it for them? Now what does, before that, I would like to put an emphasis on what exactly is a drug resistant epilepsy means. Now we have seen the benign epilepsies, they are controlled on one drug, but what is drug resistant epilepsy? When the patient is established to have drug resistant epilepsies, you will have three things. First thing is you will have uncontrolled seizures. Despite taking medicine, you will continue to have seizures. Second thing is you will have to take drugs for, you will have to take drugs for uh, sorry, yeah, you will have to take drugs for long years. So there comes the side effects like mental retardation, gum hyperplasia, and this injuries and all. And then anti-epileptic drugs comes with a majority of plethora of side effects like mood changes, bone marrow changes, liver changes, all those things. So, and you have to keep monitoring those anti-epileptic drugs levels and their side effect profiles. So when you say drug resistant epilepsy, it comes with three things. One is uncontrolled epilepsy. It's not in your control. It's totally, your life is totally uncertain. Secondly, the anti-epileptic side effect profile. Third one is unwanted injuries because of the repeated falls or burns or something. So basically, this is a complex thing physically which patient experience. Now, let us come to the fact how it affects socially. Unless and until you know how epilepsy affects socially, or I am talking here now, we are done with the simple epilepsies which are controlled. Now I am only focusing on drug resistant epilepsy. So all these things I am talking about will be only for drug resistant epilepsy, meaning those epilepsies or those patients whom despite on two anti-epileptic drugs continue to have seizures. Only those are the patients which fall in all this category, and I will be addressing all their issues, not for general epilepsies. So whenever the kid is diagnosed with a general this drug resistant epilepsy, believe me, he is having uncontrolled uncertain seizures. You cannot predict when he is going to have seizures, so he cannot play with the sports, contact sports or anything, cycling, swimming. It's not recommended. When these kids go to school and have seizures in the school, the majority of the, I mean the peers or the students, other students will tease them. So eventually they go into their cocoon, they are isolated, they cannot go for a sports, they cannot drive. Then they have a problems with the friends issue. When they grow up, their education is totally gone, because with the anti-epileptic profile, they cannot listen, they cannot I mean their cognition goes down. So their listening or in the school learning is hampered. So with all these things, and they cannot drive, so we can, with all these things, they do not get any employment. Majority of the industries do not employ epilepsy patients, fearing that they might have a problem with the machinery. Then with all these things, they cannot marry, of course. Epilepsy is a big social stigma, and they cannot marry. And generally, if you see, majority of the parents avoid taking these epileptic kids to the marriage or social function. And why is that? Because it's a stigma, it's a drama created. If you have a seizure in between during a marriage, then everybody will believe that I mean everybody will be disturbed. So what is the end result of all this? This kid is isolated from the school, friend circle, family, social fabrics. So ultimately he stays at home and does nothing, and his education is lost. And so although it appears very benign,